This meeting is now being recorded.
Well, good evening. Welcome to the EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker, we'd like to give an overview of our free program to those attending for the first time. So we will discuss who we are, what is our program, some upcoming events, then introduce our speaker this evening, Dr. Murray, and then have a Q&A. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter Deanna leads the Cleveland, Ohio EDS Support Group. She's on the call this evening as well. She was diagnosed with EDS in 2008, the same year my wife passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. So we introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've helped to start over 90 groups to date. Each group is given their own free website with a link from the directory and map. We receive feedback that conferences provide valuable information and social opportunities that many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Tuesday, typically at 7:30 p.m. Eastern Daylight Time. All the programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you'll find over 250 products selected by EDSers for EDSers. The store is the only funding for our program and usually covers our monthly web fees. Please visit our store and check out the helpful products that we sell. Just a brief disclaimer. This presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems now, please call 911. Always consult your doctor before making any changes to your treatment.
Our next webinar will be on November 3rd. This will be Kevin Muldowney, and he will present his Muldowney exercise protocol, which is physical therapy for Ehlers-Danlos syndrome. Kevin will offer more information about his new book, which was released in July of 2015. You can now purchase his book at a reduced price of $49. The book summary on our website provides more details. You can find it in the recent articles section at edsawareness.com or chronicpainpartners.com. On the home page, page down about halfway, and you can also reach it through the link shown on your screen now. You can buy the book through this page, and each book purchased through the link will automatically donate $1 to our EDS program. And some upcoming webinars. This is a partial listing of our upcoming speakers. Go to edsawareness.com and click on the Webinars tab to view the full schedule. For those attending live tonight, there will be an opportunity for Q&A after the presentation. Add your questions at any time by clicking the Q&A icon at the top of your screen. After typing in your question, click the orange button to submit. Our speaker for tonight is Dr. Murray, and she will talk about genetic testing in EDS for the non-geneticist. Dr. Murray is a clinical geneticist with focus on evaluating and providing care for individuals and families with heritable connective tissue disorders. She also interprets molecular diagnostic tests and acts as an assistant director of the Collagen Diagnostic Laboratory, directed by Dr. Peter Byers. She earned her bachelor's degree from Ohio University and her MD from the University of Texas Southwestern Medical School in Dallas. She first came to the University of Washington to train in clinical genetics and later pursued additional training in clinical molecular genetics. And during that time, she also completed a master's degree and fellowship in bioethics. She is a fellow of the American Board of Medical Genetics and Genomics and is board certified in clinical genetics and in clinical molecular genetics. So it is our great pleasure tonight to introduce Dr. Murray. We thank you for sharing your time and expertise with us tonight. And you will go ahead and I'll turn the microphone over to you, and you should see your slides on the screen now.
Okay, great. Well, thank you, Deanna, and thank you, John, for the opportunity to share a little information with everybody out there. I have to say, for me, it's a little unusual to be sitting by myself in my office talking to myself and knowing that there's an audience out there more broadly. But hopefully we can simulate what you would get at a conference or an in-person meeting as best that we can. So before I start, I just want to recognize that I think it's safe that most of you out there who are listening, whether it's today or in the future, have likely traveled your own path to get to where you are today in regards to your health. And it's probably a path you would not have chosen for yourself, is my guess. And my hope is that regardless of where you are in that path, whether you're just wondering about genetic testing, whether you may be currently in the process of going through a variety of genetic testing, or whether maybe you've already had testing or genetics evaluations in the past, my hope is that there'll be a little bit of something for everyone. And I also want to disclose that the information I'm going to be sharing tonight is essentially the same that I presented at EDNF earlier this year. So if you attended that talk at the conference, then this will likely be a bit familiar for you. So moving forward, let's see, there we go. Just to identify some objectives of what I hope to accomplish today. One is I want to outline the process of genetic evaluation, and for those who are either at the beginning or maybe in early stages of that, I just want to demystify what that's all about. And then I want to summarize for everybody the available testing for the different types of EDSs that we currently have, and to walk through some of the complexities and things to consider when you're making the decision to have testing, or maybe some things that will clarify what was done with your own testing or answer some unsolved questions there. So it's common for someone that we see in clinic to visit us because he or she wants to have the test for Ehlers-Danlos syndrome. And the reason that testing for this condition arises might be for any number of a variety of reasons. Sometimes it may be because they have a family member who just told them, that they were diagnosed with EDS. Sometimes it's because a healthcare provider raised the question because of something they observed. And sometimes it's because the person themselves recognizes that they have some features that seem to be consistent with a diagnosis of EDS. And oftentimes this happens when people are encountering difficult health issues and they're trying to self-educate and look for explanations. At times maybe when they saw that their healthcare providers we're not able to provide that to them in a satisfactory way. So, but I think that it's important to recognize that when somebody's thinking about getting the test for Ehlers-Danlos syndrome, that even the term Ehlers-Danlos syndrome is non-specific. And what I mean by that is if somebody tells me that they have EDS, my first questions are, one, what type of EDS do you have? And two, how was that diagnosis established? Because until I know that additional information, I really don't know what condition that we're talking about. So to provide a little bit more background from a historical perspective on why that is, the features that we currently recognize as falling within, the realm of conditions we call EDSs were first recognized over 2,000 years ago. So we've known about these things for a long time, but it's really only been in about the last half century that we've formalized our thinking around these conditions. Dr. McCusick, who is one of the grandfathers of genetics, was one of the first to summarize what we knew about the EDSs and to start assigning them types. And in the 1960s, you can see we started with 3 types of EDS that were formally recognized. Then later, only 2 years later, we were up to 5 different classifications, 5 different types. In the mid-80s, 11 distinct types of EDS were formally recognized. But then our current classification criteria, the Villefranche criteria, whittled that back to 6 major types and then another category. And, just as an indicator that the Villefranche criteria that are currently in use are not the end-all be-all, we are currently, organizing and revising the next rendition of classification and guidelines that will be used, and it's expected that those will be made available within the next year, as some of you may be familiar through the international efforts. So I mention this primarily just to remind everybody that we know that the current clinical diagnostic criteria that doctors are using are not perfect. The next guidelines will also be imperfect. And this is just the natural evolution of how not only EDS, but essentially almost every medical condition is understood. So I want to unpack the current diagnostic criteria a little bit more because it's directly pertinent to when we talk about genetic testing. So many of you may be familiar with the 6 types that are currently recognized through the information that's available online and through other sources. And out of those 6 major types of EDS that are currently recognized, 5 of them have genetic testing that can be performed to either confirm or exclude the diagnosis. Now, there can be complexities to the molecular diagnostic testing, and we're going to talk about that tonight. But also, all of these, what to test for, whether we do testing or not, is usually driven by the clinical evaluation. And for the most common type of EDS, or at least we think it's the most common, the hypermobile type, as you can see, we don't know the genetic cause in the majority of families. And so the diagnosis is the clinical evaluation. So whether your diagnosis is established by clinical criteria or molecular criteria, there are complexities and pros and cons, strengths and weaknesses either way. Now, just as a reminder, those 6 types are not the only types of EDS. I now think we've identified, I've lost count, maybe 12 to 14, something like that, different genes that cause EDS. And what you see on this slide are additional types in which we know the genetic cause, but they're just binned together in the other type of EDS category. And so we're hoping with the new diagnostic criteria to recognize and to bring awareness to these very rare forms, to give them equal standing with the more common forms so that people don't go underdiagnosed. In addition, I think it's important to also recognize that what you're seeing on this slide, were types of EDS that previously were in the older classifications that have since been retired from use. They may have been reclassified, such as brittle cornea syndrome or occipital horn syndrome, or it's been questioned whether they were actually a distinct entity at all. So again, just more evidence to highlight the complexities in trying to define the EDSs and then how our thoughts have changed over the years. Now, the take-home message for this isn't to be overwhelming or to make it seem like it's an impossible task, but just to serve as a reminder that there's not just, one type of EDS, there's not one test for EDS. And for some types of EDS, because we don't know the cause, there isn't a genetic test to have at all per se, and that at this time the best approach is a clinical evaluation by an experienced provider who's familiar with this group of disorders. So now, once the question of do I have a type of EDS is raised, where do we start? And honestly, there's not one best approach for everybody. Just like, the flavor of EDS varies individually and is unique per person, per family, the best approach to trying to establish the diagnosis may vary drastically based upon the individual circumstance. There are several variables to take into consideration when trying to figure out where to start. First of all is just starting with how did the question get raised. It's very different in the testing strategy and the evaluation strategy we use. If the question is raised primarily because of family history, somebody had a family member diagnosed, that's very different than when I'm evaluating or talking with somebody who may have already seen 30 different specialists and they're in the middle of what we call a diagnostic odyssey. They're really trying to figure out what's going on. Very different circumstances and very different approaches to how we start the evaluation. Also important to consider are the resources that are available. So, and I mean this both in terms as to what are the local healthcare resources and what does the person have available to them as resources. So, for instance, not every town has an EDS specialist or even a geneticist, and not all people can travel, can afford to travel either for health reasons or for financial reasons to see someone. And even once you've seen a geneticist, whether genetic testing may be covered by insurance or maybe something that's affordable is a whole other matter. Now, it's also, as I mentioned, important to keep in mind that sometimes genetic testing isn't even necessary if we can establish the diagnosis based on clinical criteria, and that the clinical evaluation is best thought of as a process. So while it's nice to, walk out the door from that very first appointment having the answer and all the information that you need, oftentimes it does require additional evaluations, additional testing, maybe gathering more information from prior records or family members. And this can sometimes take multiple visits or multiple points of contact, whether via telephone or email correspondence, and that can take, weeks to months, if not longer. So now, to demystify the process for those of you who have not seen a geneticist, it's important to point out not all geneticists, clinical geneticists are created equally. Not all of them focus on the same specialty within genetics. So, for instance, not all geneticists see children or adults, and certainly many do not see both. And not all geneticists are expert in the connective tissue disorders, including the EDSs. Now, most of us have had some basic training in the course of becoming a clinical geneticist with this group of disorders, but because of just how much overlap there can be and how challenging the clinical evaluation can be, not all geneticists feel completely comfortable, making the nuanced diagnosis between hypermobile or classical or some of the rarer forms. Also, it's important to try to understand whether the geneticists that you have or that you will see, whether they see themselves primarily as a diagnostician, whether they do a lot of hands-on management, or whether they feel comfortable in both realms. And this is something that has certainly come to my attention lately. Locally, we oftentimes act in the diagnostic role, but we're not the ones necessarily prescribing medications or even directing physical therapy, so we don't do as much of the hands-on management. And I think that this is, the reason that this is important to talk with your geneticist about is just so that everybody has appropriate expectations of what the goals are of the evaluation and what can be accomplished, just to minimize the misunderstanding, the confusion, and to try to make sure that everybody is on the same page. So now a few things to also be aware of when you're seeing your geneticist is that because geneticists are a rare specialty within medicine, many will have very long wait times. So this can range anywhere from, if you're lucky, a couple of weeks to, I know of some genetic practices that now have wait times well over 1 to 2 years. So, just don't be surprised when you call. If it's a couple months of a wait to see somebody, that actually would be pretty standard. Now, when you do see the geneticist, it's also typical that we have longer appointments than what, for instance, your primary care doctor may have available. So, for example, my appointments, whether it's for a new patient or a follow-up patient, are typically in the realm of about 90 minutes, so about an hour and a half. And I think everybody probably has the same understanding that most doctors do not spend that much time with you in the room just because of the way that our healthcare system is structured. So it's typically a longer visit, and oftentimes there may have been a good bit of preparation, collection of records, maybe talking with people over the telephone about your family history, your personal history, before you even walk into the door. So it may require a good bit of homework and a good bit of collecting medical records and family medical records. Now, the whole reason for doing that is because the more preparation that we can do up front, the more records that we can have available, and not just in volume. It's not just wanting to go through hundreds of pages of physical therapy records or records on upper respiratory tract infections or UTIs or things that may be completely unrelated. But it's really trying to gather the right records to make sure that we have the best information available to see as complete of a picture as we can in that 90 minutes. Many of you who may have very complex health can appreciate that even spending an hour or 2 hours, that's just going to be the tip of the iceberg for the years that you've spent seeing other doctors and having other tests done. So the more records we can gather and the more the right records that can be obtained can really facilitate that first evaluation and make it higher yield for everybody. Now, not only are the records helpful for that first appointment, but I think it's also really helpful for you as a patient or you as a family member to really try to clarify what your goals are to be accomplished during that visit, and to be really open with setting that out at the beginning of the visit. So sometimes there's a process, within those first 5 or 10 minutes of seeing a geneticist that we call contracting, where, either the genetic counselor or the geneticist may ask you, what is it that you're hoping to accomplish today, or what brings you to clinic today? And if you come forth with some requests that seem unlikely to be able to be accomplished, then there's a little bit of negotiation. So one of the more common things that I see is somebody will be referred to me for a connective tissue disorder, so they come and they think that they're going to be evaluated for things like lupus or rheumatoid arthritis, which are a whole different type of connective tissue disorder than the genetic heritable connective tissue disorders. And so getting that out at the beginning and being really clear about, that's not really what I do, but I can help you with this, and just getting everybody, in the same mindset, smooths things out, makes things much higher yield, and it helps minimize any misunderstanding or confusion. Now, when you see a geneticist, there's probably a good chance that you will also talk or interact with a genetic counselor. And genetic counselors are a very strong part of the genetics team, but you rarely see them outside of a genetics clinic, maybe in cancer clinics or in prenatal clinics, but not in your typical doctor's office. And in some communities, genetic counselors may be working alone without a geneticist. They have a different skill set, and I love our genetic counselors. They're great. They can gather a good medical history. They can take a better family history than most doctors out there. They're very knowledgeable about the intricacies of genetic testing, and they're very good about following up with patients after the visit. One key difference, or because genetic counselors aren't trained medical doctors, they can't perform physical examinations, and so this does somewhat limit their ability to establish a clinical diagnosis if that diagnosis is based upon clinical features that are typically seen during a physical exam. So if you are in a community where your only genetics provider is a counselor, they may be able to talk with you about the genetic testing options for EDS, but if it looks like the most likely diagnosis is hypermobile EDS, they will not be able to perform the physical examination to be able to confirm that diagnosis based on those clinical features. However, they will be able to help find or direct you to the closest geneticist if that's what they think is most appropriate for getting you the best diagnosis possible. Now, then getting to the diagnosis. As I mentioned at the beginning, we can talk about whether it's a clinical diagnosis or a molecular diagnosis. And the difference is, for a clinical diagnosis, there typically has to be symptoms or features that are present to allow us to arrive at that assessment. We use the Villefranche criteria, even though we know that they're not perfect, and different doctors will feel more or less comfortable about drifting away or modifying those criteria as they think are appropriate. And using clinical features, it's oftentimes not possible to really get to a very specific diagnosis. So, it's not uncommon for me or for other doctors to come to the conclusion, well, as far as I can tell, you may have what we call an unspecified connective tissue disorder. It seems consistent with a type of Ehlers-Danlos syndrome, but I can't be more specific than that. And that can be frustrating for everybody. It's frustrating for the doctors, for the patients, for the family. And sometimes that's when the role of molecular, genetic testing can be helpful to try to confirm or exclude exactly what we're working with. Now, molecular diagnosis or diagnosis through genetic testing, sometimes that can allow for a diagnosis to be established before any symptoms develop, or in the absence of symptoms, or maybe when only very mild or nonspecific symptoms are present. Symptoms or signs, I should say. So things people are feeling or experiencing, or features that are present that a doctor can observe on physical exam. Now, as I mentioned, genetic testing may not always be an option, either because we don't have a genetic test if we don't know the genetic cause, or because insurance doesn't cover it. And though I personally consider, the molecular diagnosis to be the most definitive diagnosis, it's pinpointing exactly what the underlying cause of the condition is, but that does not make it a crystal ball. So we can say, in general, a person with this type of EDS may encounter these type of health concerns or complications, but it doesn't say for you, for your family, this will or will not happen. So just to be cognizant and aware that it is very definitive and very satisfying in that way, it still doesn't write out what the future will hold. Now, to demystify genetic testing a little bit, since that's what we'll be focusing on from here on out. Genetic testing is typically performed on a blood sample, so it does require a blood draw. In some cases, it can be done on a saliva sample if the saliva is collected in a special tube, or it can be done from DNA that we can get from a skin biopsy. It's a really common misconception that the testing for EDS requires a skin biopsy. It does not, and actually blood, for a variety of reasons, is usually preferred over skin biopsy for EDS genetic testing. In the past, we did not have the same type of technology that we have now, and it was common for a skin biopsy to be required to either look at the collagen proteins that were made in somebody in whom the diagnosis of EDS was suspected, or to look at the formation of the collagen under electron microscopy. But we're moving away from that as our genetic testing has got better. Again, I won't belabor this point that it may not always be necessary or available. As I mentioned, insurance coverage does vary, and this can not only vary from company to company, so, you know, Blue Cross to, I guess Aetna is one of the other ones, to Medicare to Medicaid are all very different, but even within those large companies, policy to policy can be very different. So this is something that oftentimes your genetics provider will talk with you about if they think genetic testing is necessary, you know, into whether we need to look into pre-authorization or pre-approval, that can add some time onto the process. Now, once the sample has been collected and has been sent to the lab, and oftentimes, you know, oftentimes the blood or the DNA sample has to be sent to specialized labs across the United States, then the turnaround time can be anywhere from 2 weeks to about 4 months. It depends on the specific test, and I'll go over that a little bit more in more detail in the following slide. So now, when we talk about genetic testing, that, you know, the past slide gave a little bit of information on the sample type and the need, you know, some of the logistical factors with insurance and sending it to a lab. But not all genetic tests are exactly the same. It actually is also a bucket term for many different types of testing that can give us different information and that uses different methods within the lab. So the two most common general methods or general types of testing you'll hear is whether we're going to do gene sequencing, which is basically a spell check of the gene from the beginning to the end of the important region, versus whether we're going to be looking for larger deletions or duplications in a gene that our spell check might miss. There are different, so those are the different methods. And then we can do different tests depending upon what the question is. So if somebody in your family or if you yourself have had genetic testing and they've identified the precise exact genetic cause for the type of EDS in your family, then for anybody else in the family who wants to be tested, we know exactly what to look for. And because we know exactly what to look for, it makes the test very straightforward, very simple, and much less expensive. We just hone in right to that one thing that we know is present in the family, and it gives us a clear yes or no. We call that known variant or sometimes known mutation testing. Now, that's different than if I feel that we think you have this type of EDS. We don't know the precise genetic cause in your family yet, but I feel fairly confident that it might be classic type or vascular type. Then I'm going to look at either a single gene. So for instance, in vascular EDS, it's the COL3A1 gene, or in classic EDS, it's COL5A1 and COL5A2. So there's two genes there. So I want to look at that gene, but I have to look at the entirety of the gene from the beginning to the end because I don't know the exact precise change. So that's a different test. It costs a little bit more and it takes a little longer to do. Now, more recently, another type of testing that has entered, or I guess has become available, is where I don't know precisely what type of EDS, or I can't hone it down to be that discrete. So instead, I'm going to test for multiple types of EDS, maybe for every type of EDS, and for other genetic conditions that can overlap with EDS, such as some of you may have heard of Marfan syndrome or Loeys-Dietz syndrome, other genetic conditions, not EDS, but they can overlap. And our technology has advanced such that now we can just look at not one gene, not one type of EDS, but a much more comprehensive approach in multi-gene panels. These do take longer oftentimes because we are looking at more genes. But because the actual lab technique is different, actually sometimes these may take exactly the same amount of time, but they may cost more. So you would want to talk, when you're thinking about this specific test, really talk with your genetics provider, the provider helping you, about exactly what the cost is in turnaround time. And then for some families, we get to the point where either we've exhausted all of the testing, the single gene, the multi-gene panels, and we still haven't got an answer, or where the clinical picture is just so complicated, we think that we need to look much more broadly. And those are the cases in which we might consider a type of test called either whole exome or whole genome sequencing. This is essentially, and I'm going to simplify it because it's a little bit more complex, but it's essentially where instead of looking at one gene or a handful of genes, we just look at all 20,000 genes that we have in our genome. It does miss some things, and it's not always the best test, so this is a circumstance where more is not necessarily better. But in some circumstances, this may be the best shot we have for getting to the right answer in a very time-efficient way. So now, talking about costs, right? Because if insurance coverage is an issue and if costs are an issue, to try to give you a better idea of exactly what we're talking about. As I mentioned, simple is oftentimes quicker and cheaper. And so for known variant testing, the range of cost is usually about $250 to about $600. So this is oftentimes in the range of, say, getting a blood chemistry or a lipid panel, getting your cholesterol checked. It's about the same. Now, single type testing, so I think you have vascular type, so we're just going to test for that, or I think you have classic type, so we're just going to test for that. That is more in the, a couple hundred to a couple thousand, depending on the specific test and the specific lab. And so this is more in the range of, say, a series of x-rays, or maybe even a CT scan. The multi-gene tests can range in cost anywhere from about $1,000 to, I've seen them as expensive as about $5,000. And so that's getting much more into the range of an MRI exam, something like that. So again, you're going to want to ask, if you're doing testing, what's the specific cost of the test that your doctor's recommending for you? Now, when we do the testing and we get the results back, what we're really asking the lab to do is to identify genetic variants or variations in genes and to interpret what those variations mean. Now, all of us, for example, if we're going to use vascular EDS as an example, if all of us had the test for vascular EDS, the majority of us will have variations in that gene, but do not have vascular EDS. Because most of those variations are just normal, benign, not disease-causing, not harmful variations that may run in our family and that are just part of normal human genetic variation. So we all have millions of variations in all 20,000 of our genes, and most of those do not cause any type of ill health consequence. So we call those, let me see if I can get my cursor up here. Hopefully you guys can see that. So we call those benign variations, and the vast majority of variations that are identified and that we have are benign. Now, sometimes the labs may identify a variant in a gene that for one reason or another, they're not absolutely sure that it's benign, that it doesn't cause any ill effect, but they're pretty sure. So the typical number that's used is if they're 95% sure that this does not cause any health consequence, then we will call that likely benign. And for the most part, what that tells me as a clinical geneticist is that even though we saw this variation that may be relatively rare, that I need to keep looking because this is not the answer for this person. Sometimes we find variations that we just don't know. We don't know if it's benign or if it's disease-causing, and we call those variants of uncertain significance. To give you an idea, if we just pulled anybody off the street, for most of our well-studied genes, the likelihood of identifying this is about 5%. So about 1 in 20 people in any given gene will have a variant of uncertain significance. And whether or not we can resolve that uncertainty depends a little bit upon the specific nature of that variation, whether there are other people in the family who we can test to see if it travels with the EDS features in the family, and whether there may be protein or other studies that we can perform. Now, there are also times when we identify variations where we can't be 100% that it's the cause, but it really looks like the smoking gun. It really looks like this is the explanation. And in that case, we'll call it likely pathogenic. And then when we know absolutely 100% this is the cause of EDS in that person, we'll call it pathogenic or disease-causing. Now, if a variant falls into this category where it's likely pathogenic or pathogenic, it looks like it is the cause of EDS, we can use that information not only to definitively or almost definitively establish the diagnosis, but I can also use that information to base medical recommendations on, should we be doing something different? Should there be medications that we should be prescribing that are different? But also for testing family members who may be at risk. So oftentimes it's that there are children that somebody's concerned about, or siblings or cousins, and if the variant is identified and if it's classified as likely pathogenic or pathogenic, then that information is really golden. So now this next slide is, I just tried to make a diagram to try to explain these variants a little bit more, so just bear with me as I kind of orient everybody. So if every circle here is an individual, and every horizontal line of circles is a family, and every clustering is a population or a group, so different ethnicities or different populations, then sometimes, say this is me, and we identified a genetic variant in me. One of the first questions we will ask, if we're not sure what it means, is one, did I inherit this through my family, or did it arise brand new in me? Now, we all have variations, just like we all have millions of variations. A handful of those variations are ones that arose anew either in the egg or the sperm that went into creating us, or that maybe arose when we were an embryo or we were developing very early. So it's not something that's present in our family. It's unique to us. And whether that is meaningful depends upon the type of variation it is, whether it's in a really important gene, and also whether it's in a gene that causes EDS, if that's the specific concern. And as you can imagine, because these unique variants are quite rare, sometimes they can be really difficult to understand what they mean. Now, sometimes we will see variants that are rare, but we can track it back through multiple generations. It's rare that we can get through, 7 generations, but sometimes we can get to 3 to 4 generations. And we can see, okay, this is just tracking through the family, and it may or may not associate with the features of EDS. So now if it does, then this can be helpful for letting us understand, okay, this is likely the cause of EDS in this specific family, even though we haven't seen it in any other families. Or alternatively, if we're seeing it in members of the family that do not have EDS, so it's seen in healthy members, then what that tells me is, yes, this is a rare variant, but it's not the cause of EDS for this person in this family. And so I need to keep looking. Now, there are other times when we see genetic variations that may be very population specific, so it may track in one or multiple families in a population, but we do not see it in other populations. And so this can be a little bit tricky, because if all of a sudden it pops up in one person from this whole other population, it could be because, you know, for instance, they're interracial, or because their family has migrated from somewhere, or because it arose new in them, but we already know because of our observations in other people that it doesn't cause disease. But it can lead to a little bit of, I guess, uncertainty, or alternatively, it also can be reassuring if we know, yes, you know, this is a variant that we see most common in Native American populations, or in Caucasian populations, or in Asian populations, and that fits what we know about this person. So now, to some limitations of the testing. As I mentioned, with those variants of uncertain significance, sometimes we can get inconclusive test results. But even sometimes if we know definitively this is the cause, it may not actually change healthcare recommendations. So it may not help us take better care of somebody, even though we've definitively established this is 100% the cause of why they have a type of EDS. We've also encountered the circumstance where somebody has a really striking clinical diagnosis. So I feel beyond a doubt they have classical EDS. They've got the skin findings, they've got every other feature, but I did the genetic testing and it's normal. So now that doesn't necessarily mean that they do not have that type of EDS. It may mean that they have a very complicated genetic mutation that our technology couldn't detect, or it could be that there's something more complicated at play. But just to be aware that if we're fairly certain of the clinical diagnosis and we don't need the genetic test to confirm that or to test other family members, then genetic testing may not add much in that it doesn't change care, and there's a chance it could come back normal, which doesn't necessarily change anything. And then sometimes what happens is that now that we're doing more of these larger tests and looking for syndromes that can overlap with EDS, that we can get unexpected results where maybe they have a variant or even a pathogenic variant in a whole other gene that didn't really seem to be what we were dealing with. And sometimes that can help clarify things and help us take better care of people. But sometimes that can lead to some uncertainty and discomfort and complexity. Now, one note that I did want to touch upon is everything I've been talking about so far has been with clinical genetic testing that is done under the supervision and with the recommendations of a healthcare provider, whether it's a geneticist, a genetic counselor, your rheumatologist, your physiatrist, some healthcare provider. But many people are familiar that there are types of genetic testing that can be done on what's called a direct-to-consumer basis, meaning you don't need a doctor to order it to you. You spit in a tube, and maybe you send it to 23andMe or one of the other companies, and that they then give you back your information. Now, this is different than clinical genetic testing. It uses a different methodology. It gives us different information. The samples are often handled in a different manner. And for this reason, many clinical geneticists either will not or will not happily use that information if somebody even brings it in hand with them to clinic. And it's not that we want to be elitist or that we want to be snobby about it. It's just that we recognize that it's just a different test, and it's not the same test that gives the same type of information as we get from the clinical tests that we order. And I've had a number of people who have come to see me because they say, I have vascular EDS based on my testing that was the testing was done at 23andMe, and the results were interpreted through LiveWello or through one of the other companies. And when I look at it, it's true that they had variations in the gene in which pathogenic variants cause vascular EDS, but the variations identified in that person were not disease-causing. And I think part of it is that the reports can be very confusing, and all of those nuances to genetic information and genetic testing can be easily misinterpreted or maybe not well explained by the companies, not purposefully, not because they want to deceive, but just by nature of the restrictions that are placed upon them and by nature of the methods that they use. So just be aware that if your particular goal of doing this type of testing, this direct-to-consumer testing, is for a health-related reason, talk with somebody who knows and understands the test before you spend your own money on it. Now, these tests can also be done for what we call recreational reasons, right? Ethnicity testing. I think there's even nutritional ones that are done now and other things. And that's all good and fine, and that's not clinical, that's not for health reasons. But if really your motivation is to do it because of your health concerns and your desire to get a diagnosis, talk with somebody first because it may not give you the information that you want. So now, when the question comes up, should I have genetic testing? It really depends upon your specific circumstance. In general, if there is a known pathogenic variant in your family, so the diagnosis of a type of EDS has been confirmed with a genetic test in your family, and you want to know if you have it, the best way to answer that question is with the genetic test. And while we always like it when people see a genetic counselor or see a geneticist, the truth is that test could be ordered by any of your healthcare providers, whether it's your cardiologist or your primary care, as long as they're comfortable ordering the test. And as long as you know what the results mean for you. So in that context, then the genetic testing is the way to go, hands down. It's pretty straightforward. If the clinical diagnosis is not established and you really either want to have diagnostic certainty, want to exclude possible diagnoses, so, a common thing that we see is I really think, this person has hypermobile EDS, but I really want to be sure they don't have the vascular type, then I may test for the vascular type, knowing it's unlikely, but just to exclude it or to roll it out as much as we can. And then the other time for clinical diagnostic certainty is also if the genetic test result would change clinical care. And sometimes whether it's positive or negative may change the recommendations, not only of the geneticist, but maybe of a surgeon, maybe of a cardiologist or somebody else. So those are definitely times when it makes a lot of sense to have the genetic testing. Now, if the clinical diagnosis is absolutely certain, so I don't care what the test result tells me, you still have this type of EDS. Even if it comes back normal, you have this type of EDS. Well, the times that can be helpful is sometimes the specific genetic cause can give us a little bit more insight onto the overall prognosis. So, for instance, within the realm of vascular EDS, certain types of pathogenic variants may lead to a milder clinical course than what is described and what a lot of people read about with the more typical type of vascular EDS. So it can be helpful in that regard. Sometimes it can be helpful for people who are thinking about starting their families and they want to have biologic children. Then knowing this precise genetic cause makes available a whole menu of reproductive options that they can use either for prenatal testing, pre-implantation genetic diagnosis, or even testing a baby as soon as it's born so you know with certainty, yes or no, he or she did or did not inherit EDS. And then the other reason to consider it is similar, and it's to make available family testing, either for children, for siblings, for cousins, for parents. So the only way to really have specific testing available for them is if we can identify it first in the person who has EDS. So now the issue of the Lineage Test, I hope, I at least was able to give the impression that which test is the, quote, best test really depends on the specific circumstance. There's not one best test for every person, and more is not always better. So just to conclude quickly, what I hope the takeaway is that, there is not one test for EDS because there is not one EDS. It is a group of distinct disorders with many different molecular causes, and that they can have overlapping features in which genetic testing can be helpful. That whether you use clinical criteria or genetic testing, getting to a specific diagnosis can be difficult, even for people who are expert in EDS. So just to prepare people that it can be a long road to travel in trying to get to that diagnostic certainty, and it can take time. And that genetic testing is available in a variety of ways, whether it's known mutation testing for something we know is in your family, whether it's known EDS testing for a specific type, or whether it's a much more comprehensive panel. There is testing available. It may be helpful and can be indicated, but it really does depend on the circumstance, and that's where it can be helpful to talk with somebody who knows about it. And just as a side note also, if you have been diagnosed with EDS and it's been 20, 30, maybe even longer since that diagnosis was established, sometimes it's helpful just to check back in. It may be our testing has changed drastically in that time. Genetics has changed drastically in that time. And so sometimes just touching base to see, would genetic testing tell me anything new? Would it be helpful for my family? And are we sure that this is still the right type based on what we now understand of the EDSs? It can be helpful sometimes. So with that, I just wanted to thank John and Deanna and recognize all the good work that they're doing with EDS awareness and extend my appreciation for having this opportunity to the folks out there with EDS, the clinicians, and then to acknowledge my local support here. So with that, I think, yeah, Deanna, is that you?
Thank you, Dr. Murray. This has been a really, really great insight into testing that I think a lot of the patients have a lack of understanding about. So this is going to help a lot of people. And thank you for all the excellent information. I know we do have many questions from the live attendees. So if you're able to go over to the Q&A section and pull up the list of questions.
Okay, I think I have it open. So I think the first question from the woman in Alabama, I think I actually emailed her earlier today. So I am going to skip over that one. Okay, and there's another question about 23andMe. I hopefully had touched upon that one. The question is specific to a geographic region. I honestly don't know many of my clinical genetics colleagues who will happily interpret genetic test results from 23andMe for all of the reasons that I mentioned. And again, just to remind folks that 23andMe, their testing identifies variations in genes. Most of those variations are not pathogenic. So, just to be careful about how you look at them and think about the difference between a mutation as a pathogenic variant versus the vast majority of variations which are not pathogenic. I can also forward my contact information if I'm just breezing over somebody's question and I don't answer it thoroughly. And I can forward my contact information to Deanna and John, and we'll be happy to triage some of the more specific questions separately. So now this is a good question about tenacin X and the tenacin X genes. I did not mention this. When we talk about hypermobile EDS, I had said that we do not know the genetic cause in the majority of families. Now, there was there is a recognized genetic cause of hypermobile EDS in a small minority of families. The estimates range about 5 to 7%. And the gene is called TNX-B or tenacin X. Now, this gene was first recognized as a cause of EDS in a very rare form in which individuals, so we all have 2 copies of most of our genes, and recessive forms of EDS arise when people have pathogenic variants on both copies of their genes, so they don't have a normal copy, both copies are abnormal. And in tenacin X, that leads to a very striking autosomal recessive form of EDS. And then when we looked at the parents of those individuals, it was seen that about 80% of the females in those families who had just one mutation also had features of EDS. So a little bit of a complicated picture. But then when we then started looking at the patient population more broadly, saying, okay, let's not start with families that have one person with this very rare form because both of their copies are abnormal. But let's just look at people who have hypermobile EDS. We did not see tenacin X as the majority, as a cause in the vast majority. So more than 90% of people did not have a mutation in that gene. And in those cases, or in those remaining people, so 90% or plus or more, we based the diagnosis off of clinical features. So how much hypermobility is present? Do they have features suggestive of other types? And I personally think that when we solve, and again, this is personally, right? So this is not necessarily what other geneticists think. This is just based off my own observations. I think that when we finally get lucky enough and smart enough to solve the cause of hypermobile EDS, what we will find is that it's not one thing, that there are many different genes that can cause very similar clinical pictures. And I think that even in one individual, there may be more than one gene at play, more of what we call complex inheritance, where it's not one gene, it's several genes that are feeding into the risk. And it may also require certain environmental factors. So we know hypermobile EDS is much more common, at least the people who get evaluated and get diagnosed with hypermobile EDS, it's much more common in women than men. And we assume it has to do with hormones. We don't know for sure. It makes a nice story. But so I think that what we'll see is that hypermobile EDS is not one thing. I think there'll be not just several, but many genes involved. And I think there may be also a role for environmental factors at play. So that is what, I think that's what's making the diagnosis very complicated. The diagnosis is currently based on clinical features. And I think that this is one case in which you'll find, depending on the specific provider you see, whether it's a rheumatologist or a geneticist or somebody else, and depending on what their specific philosophy and understanding of it is and what their experience is, one person may be told that they have nothing, may be told that they have joint hypermobility syndrome, or may be told that they have hypermobile EDS. So just really highlighting the inconsistency that we hope the new diagnostic criteria that we're expecting in the next year, that we hope will help make life better and easier and lead to better diagnosis and better diagnostic tools, both for families, patients, and providers. So I think that question came from Steve, and hopefully that addressed it thoroughly, or at least somewhat better than it was addressed before. And sorry, I'm scrolling down here. Okay, so the next question was also, this one was from Linda, in regards to the diagnosis of hypermobile EDS without genetic testing. But in this case, the question was, what about if there are crossover features with vascular form? So again, I think every doctor has a little bit of a different approach, and this is not only in EDS. You know, many doctors will have either a more hands-on, testing-heavy approach versus hands-off, you know, kind of testing light approach. When the question of vascular EDS comes up, whether it's because there are some features that are crossover, and it really depends on what features you're talking about. You know, if it's something like easy bruising, well, that happens commonly in pretty much every form of EDS. But if it's something more specific, like they had an arterial event or maybe had a surgical complication that was really outside, you know, the realm of what we expected, then, and by that I mean with tissue friability and with, you know, the surgeon saying this person, their tissues handled very differently than what I expected. I tend to have a low threshold for at least offering the test for vascular EDS. And that's not saying it's right or wrong. That's just my personal clinical approach because I've seen enough cases in which I feel like based on clinical features, I look at their genetic test result and they have it, and I'm looking at them across the room from me, and I would have never guessed. So I've seen that enough times that I've become very humbled, and because I know as a doctor, even though I may feel like, no, you don't have this, I feel comfortable, I'm not losing sleep at night, but I'm not you, right? And if the question is unanswered in your head, in my patient's head, and they're still up at night with anxiety that maybe they have the vascular form and maybe they didn't see the right doctor or they didn't share the right information, you know, that's, as a doctor, I don't see that side of things. So if somebody brings it up to me, if somebody really wants to have it done just for certainty as much certainty as we can get, or if there's something funny, I have a low threshold for offering it. Different doctors will do things differently. I don't know that there's a right or a wrong. And so if you saw a doctor who doesn't feel like that test is indicated and you're not quite satisfied with that approach, then my suggestion would be seeing if you could get a second opinion or seeing if maybe there's a genetic counselor or somebody you can talk with a little bit more in depth who may help you better understand, you know, why that is or isn't and what the hesitancies are or why that is. So hopefully that answered that question a little bit. So there's two questions from Kim. One is about confirmation of a diagnosis with a genetic test. And the example provided was, well, what about things like Marfan syndrome where some features can overlap with EDS? I think it depends on the clinical picture of the specific circumstance, and I think sometimes it is appropriate and sometimes it may not be appropriate or helpful. So I can't give you a clear yes or no as to whether, you know, genetic testing is always appropriate or necessary, and I would encourage you to talk with someone, maybe if you've seen a geneticist or if you think about seeing a geneticist, to talk with them a little bit more about your specific concerns and circumstance. And then the follow-up question to that is, well, is it proven that an early diagnosis and intervention has better outcomes? And, you know, for many types of EDS, so many of the very rare forms, I think it was on the second table slide that I had put up there, they're just so rare that we have not done the studies to know what interventions make a difference. With the common types of EDS, and by the common types I'm going to say classical, vascular, and hypermobile, we are also lacking in what in the medical field is called evidence-based outcomes research. So have we done big research studies proving that if somebody avoids contact sports, it saves their joints? Or proving that if you work with a physical therapist on your core strengthening and proprioception and all of those things, that it makes a difference. we don't have a lot of evidence-based outcomes research to say definitively yes or no. That's true of many rare genetic disorders, not just the EDSs. And even in vascular type of EDS, we talk about things like whether people should have their arteries and their blood vessels looked at routinely with MRIs or echocardiograms. We don't even know if that makes a difference, if it really improves outcomes. So at this point, we base our recommendations largely off of what's considered either expert guidelines, so what are the experts telling us to do, what do we agree seems like the best thing, or based purely off of clinical judgment. For one reason or another, this recommendation makes a lot of sense. It doesn't introduce a lot of harm, so we have potential benefit and probably not a lot of detriment to trying these things. So the short answer is no. The long answer is we do the best we can with the evidence that we have. And then the side comment is this is also the reason why we need more research, not only on the genetic cause of EDS, but also on what makes a difference, what changes the natural history, what actually helps and what doesn't, and what harms people. So hopefully the future will take us in that direction. So moving on to the next question. Hopefully I touched upon this. Can any doctor order a genetic test? Yes. Any doctor can order a genetic test. Primary care can order a genetic test. Family doc, genetic counselors, even without a geneticist, can order a genetic test. If they're not familiar with the best test for your specific clinical circumstance, sometimes they can just call the lab to talk with a genetic counselor. So, for instance, this isn't a commercial plug. I don't mean it in that way, but at the lab that I work at, we have 2 genetic counselors that are usually the ones who are the first line on the phone. And they talk with a lot of doctors about, you know, tell me about your patient. What are your concerns? You might want to consider this test, or this test doesn't make a lot of sense. So it's not just our lab. Almost every other commercial lab has 1 or more genetic counselors that are available to help if the only doctor that you have available to you is your primary care and your primary care doesn't know what to test for. So absolutely, yes. Let's see here. I'm sorry, just scanning over a little bit more. So there's a question I mentioned about that we don't know the cause for hypermobile EDS. There are a variety of places where that research to try to identify the cause is happening. So for instance, at EDNF this year, they were collecting saliva samples from anybody with a diagnosis of hypermobile EDS to participate in research to do whole exome sequencing, that type of technology where they look at all 20,000 genes. And I know there's not just one site. In a lot of places, the genetics research is collaborative. So people work together, whether they're at Boston or Baltimore or Houston or Cincy or Seattle or San Francisco, where we all are kind of working together to try to solve that particular problem. So I don't know if EDNF is still looking for people to donate samples, but you might want to look on their website to see if they have more information about the research study they were collecting samples for at the conference this year. And then a question about what % of genetic testing is accurate versus inconclusive. So some of the nitty-gritty details of genetic testing I did not get into because oftentimes it's not necessarily what's really clinically the most helpful thing for people who don't know about the lab part of things. When we talk, whenever genetic tests are developed and offered, the lab has to prove several different things that are characteristics of the quality or the goodness of the genetic test. And by that I mean some of the terms we're all familiar with, so how sensitive is it? And sensitive in scientific terms means if I have 100 people who I know have exactly the same thing, these people all have vascular EDS, and if I test COL3A1 in all of those people with this test, you know, how sensitive is it? How many people are going to be found to have the mutation? And then the other side of that coin, how specific is the test? So if the test tells me that this person has a pathogenic variant, how specific is it that that means they do have vascular EDS? And I apologize if this gets confusing. It's very kind of technical scientific terms about the sensitivity and specificity that we usually trust the lab to establish. So you'll oftentimes see, you know, in people with vascular EDS where we're sure based on the clinical features they have it, the sensitivity is, you know, greater than 98%, you know, versus how specific it is a little bit harder because we don't always know the people we're missing. Then we also talk about things like false positives and false negatives, so how many people will test positive but they don't actually have it, maybe because the method made a mistake, the technology made a mistake, or how many people really have it but we're going to miss it. And then we also do things like look at what's called analytic validity, which is how good the technology is, clinical validity, how good is this a test for establishing the diagnosis, and clinical utility. So a whole hodgepodge of terms that if you're in the scientific world, if you're in the world, it makes a lot of sense, but I only bring it up here not to confuse everybody and to make everybody start scratching their heads, but to let you know when we talk about how good the test is or what percentage of the time will it be accurate and helpful, it really depends on more specifically what the technical question is. So I can't provide one good answer, but it is something that labs look at, and many labs will make that information available. If you're looking at a specific test, how sensitive is it? How specific is it? What is the clinical utility that is usually publicly available and something that can be looked up for the specific test you're thinking about? And that will vary based upon the type of EDS you're testing for and whether you're doing a single gene test or one of these big panels that's much more comprehensive. Another question, so Kim, you've been very busy asking questions. I like it. It's good. You've had good questions. This one also comes from Kim asking about how much weight is placed on the Beighton score. So now the Beighton score is one of the clinical features that are used to establish a clinical test or a clinical diagnosis of hypermobile EDS. And how much weight is placed on it, honestly, it depends on the doctor. I have talked with, just thinking about my colleagues who are EDS specialists, some of them will really not place a lot of weight on the Beighton score, but will kind of take a history of hypermobility as being sufficient. In the context of other health complications that are suggestive of hypermobile EDS. I've also talked with EDS experts who say, you know, I really think we placed the bar too low, and I really think hypermobile EDS is when somebody has a Beighton score of 8 or 9, so really high Beighton score. Just for those of you who may not have heard of this before, the Beighton score looks at, it's a 9-point assessment, looking at how far back your pinkies go, whether you can touch your arm to the forearm on the same side of your body, whether you hyperextend at the elbows greater than 10 degrees, whether you hyperextend the knees greater than 10 degrees, and whether you can place your palms on the floor. I always tell people with your knees straight and your feet together, but that's not actually specified in the Beighton score. But you can imagine if your feet are spread far apart, it's easier to get your palms to the ground than if your feet are together. Similarly, if you bend your knees, it's a lot easier than if your knees are straight. So there's variation in how doctors assess the Beighton score. There's variation in how much weight they put into it. And this is another, I know, has been an active point of conversation with the committee that's trying to refine the diagnostic criteria for hypermobile EDS. in the next rendition. So then moving down, how is EDS passed down in the family? So that's a really good question. I actually just skimmed over that. There's different inheritance modes. The two most common ones we think about are called either autosomal dominant or autosomal recessive. With autosomal dominant, it means that there's one pathogenic variant in one copy of whichever gene it is. And so if a person has that form of EDS, then it's a 50-50 chance whether they pass on the copy with that variant or whether they pass on the other copy. And so that's the autosomal dominant inheritance. And for classical EDS, for vascular EDS, for arthroclastic type of EDS, which is a rare form, that's the inheritance mode that it follows. For the rare forms of EDS, it follows autosomal recessive, meaning that you have to have two pathogenic variants, one in each copy of the gene. So most commonly what we see are that parents are healthy carriers where they typically have no features, and then they have an affected child because the child inherited both abnormal copies from them. They used to talk about hypermobile EDS as being, and we still do, talking about it being autosomal dominant. But as I mentioned, I think in some families that it's more of a complex inheritance pattern, and I think that's why it's been so difficult to pin down. That is not proven. That is just my personal opinion. But I think that that may be at play in some families, in which case how it is passed down depends upon the shuffle, the number of genes, the shuffle of genes the child inherits, and what they're getting from the other side of the family. And maybe even what sex they are or what other environmental risks they have. So then scanning down through the rest of the questions, it doesn't take a geneticist to diagnose hypermobile EDS. That's the question is, can only a geneticist diagnose it? Other doctors can, and other doctors do. Locally, I've noticed our rheumatologists will oftentimes arrive at that diagnosis, but other specialists can. It depends on how comfortable they are and how familiar they are. And I already talked a little bit about research. And are they getting closer to the gene for hypermobile EDS? They're trying. We're all trying. We really are. I think it's not that we're not smart enough. It's not that there's a lack of effort. I think it's really complex. How to find a doctor knowledgeable in EDS is the next question. One resource is by, looking to your peer group, whether it's EDNF or if you have a local group. They may be knowledgeable about which doctors in your area know EDS. That would be probably where I would start. If you don't have that available to you or you're not finding answers there, reaching out to the local genetics providers, even if they're not EDS experts, they oftentimes will kind of know who's the closest person to you that is. The way to find a geneticist, if you aren't familiar, most of us live and practice within major academic centers. So if you have a major medical center, they will usually have a clinical geneticist available, or you can look at I think it's either the American, there's a couple different places, the American College of Medical Genetics or the American Board of Medical Genetics has a database that you can search, or to find a genetic counselor, it is I think it's either the National Society of Genetic Counselors or the Accreditation Council of Genetic Counseling. So there, you can find providers also through those public databases. So getting down a little bit more, and I do want to just say that I have about 5 more minutes that I can take the questions, and then I do have another obligation I have to go to, so I can also follow up questions via email if I don't get to everybody's. This one's a long one. So talking about how it may not be cost effective for everybody to have whole genome sequencing, but are there statistics that show that other diagnoses show up during whole genome sequencing that are a surprise and that we wouldn't have found? Okay, so I get the question. So it costs a lot to do whole genome or whole exome sequencing, but what's the chance that we could find something there that we wouldn't have tested for if we had only looked at a single gene or multiple gene test? Yeah, so this is an interesting question. We're still, I guess, gaining experience with the clinical use of whole genome and whole exome sequencing. People are looking at this question, and there has been some research done in what we call incidental findings, meaning that we did a whole exome or whole genome sequencing for one reason. It may or may not have answered that question, but oh, by the way, we found these other things that you might want to know about because it may change your health care. So one of the common examples, and actually the American College of Medical Genetics has a list of, it's either 56 or 58 conditions, I always get it confused, that labs are supposed to look for, and most of those are related to cardiac conditions, such as a risk for rhythm disturbances that can lead to sudden cardiac death, that can lead to aneurysms, or cancer syndromes that maybe people would want to have cancer surveillance at a younger age, or through a different means, or even have preventative surgeries or preventative medications. So those things may be completely unrelated to EDS, may be completely unrelated to why the test was done. It's still important to know. And in our local experience, these incidental findings are relatively uncommon. I think it varies depending on the lab and their threshold for reporting them. Locally, if I remember correctly, I think the likelihood of getting a clinically actionable incidental finding is about 1%. I've seen some national presentations where it's more like 2 to 3% of people. So certainly, not the majority. Other labs may look at more things than just that core recommended set of genes, so they may have a higher rate of incidental findings. And sometimes labs will offer reporting what they call candidate genes, meaning we don't know if this is the cause. It's not been associated with EDS. It has not been associated with anything to date, but it looks concerning either based on the biology or based on animal studies or something else. And so would that be considered a type of incidental finding or potentially identifying a novel new genetic cause for what's going on? So a little bit of a different issue, but something else some labs will report but not. So I think we still have to look at the cost effectiveness, the clinical implications of those type of results, whether some people are coming to harm as opposed to benefit for getting that information, and just how common they are. I think that'll be coming to light more and more over the next couple of years.
Thank you, Dr. Murray. Oh,
sure.
Okay. Any last words you had for us?
No. So I know that sorry, I was just reading down through them. I know there's still some unanswered questions. Deanna, were these questions, are these things that I can still access after we wrap up here, or will they be kind of offline and unavailable?
Yes. We can capture those for you if you'd like. We can also post your email if you want us to on the same page that people use to log in and the page that the recording will be placed on.
Okay, great. Yeah, then what I can do is for those of you who had the questions that I didn't get to or that maybe I got it completely wrong when I tried to answer it, then I will get those off of Deanna and I will try to type brief written responses and hopefully get you some of that information.
Okay. Thanks, Dr. Murray. Thank you so much for your time in doing this. We appreciate you guys so much, you and Dr. Byers and your staff at your lab. You guys have always been real great advocates for the EDS community and just really good, very willing, to help us with any questions that people have when they come across some, conundrums about testing. I really appreciate you explaining everything to us and guiding us along in that process.
It's certainly something that we enjoy, and I'm speaking to the choir, right? It's a challenging circumstance, and it's nice to work with groups like yours and like EDNF who are trying to just help everybody navigate these difficult waters together. Okay, so thank you so much. Yeah, thank you all, and I hope it was helpful, and I will follow up for any answers to the questions I didn't get.
Wonderful. Thank you so much.
Okay, thank you. Bye-bye.
Good night. Just want to remind everyone that our next presentation will be November 3rd, and that will be Kevin Muldowney, and he will talk about his new physical therapy book that was just released in July, so don't miss that.
And I just want to remind people that our sponsor is Body Support Store, where you'll find over 250 products selected by EDSers for EDSers. It's the primary funding for this program. It makes this program free for all of us. And so go out and find something that you feel that might be helpful for you. So again, thanks everyone for joining, and we appreciate your attendance. The recording and the slides will be posted tomorrow. So again, good evening. Thank you.
Have a good evening, everyone.